Hello, this is me, Dr. Waladin, and welcome to our topic today. This is a comprehensive GP-focused summary of rabies tailored for clinical practice in Oman, based entirely on Communicable Diseases Manual of Oman, 3rd edition, 2017. So let us deep dive on that topic with our guest today.
Today, we are looking at a stack of really intense clinical summaries, all focused on one of the most, frankly, frightening viruses known to medicine, rabies.
It's a topic where the stakes are absolute. We're talking about Lissa virus type 1, an acute viral encephalomyelitis that, once you see symptoms, is almost universally fatal.
Exactly. And our mission today is to sort of translate this dense material into simple, critical insights for you. The information we have is tailored for clinicians, but the core knowledge is something everyone needs to understand.
It is. The virus is from the Rhabdoviridae family, and it's zoonotic, meaning it comes from animals. And the global picture is, well, it's grim. We're still seeing 35 to 50,000 deaths every year.
Which is just staggering for a disease that is, in theory, entirely preventable.
And that number really highlights why humans are considered a dead-end host. Once the virus gets into our system, it's a one-way street to the central nervous system. Prevention is everything.
So that means post-exposure prophylaxis, or PAP, it has to be started immediately?
There's no other option.
Okay, so let's talk about the reservoirs. Globally, we know dogs are still the main source for human cases.
That's right.
But the source material you provided points out that, depending on where you are in the world, the threat really shifts to specific wild animals. Things like foxes, wolves, jackals.
And this brings us to a really fascinating case study in epidemiology from Oman, actually.
Right. What's so interesting here is the local history. Before 1990, the region was essentially rabies-free.
A completely clean slate. Public health officials had, almost zero baseline risk to manage. It wasn't on the radar in the same way.
And then it all changed. The sources pinpoint one single pivotal incident.
The very first human case in 1990.
Caused by a fox bite in a place called Yunkel City. And that one case, we learned, was the beginning of a rapid nationwide establishment of what's called sylvatic rabies.
And that's a crucial distinction. Sylvatic rabies means the disease is being maintained exclusively in a wild animal population. It's independent of domestic dogs.
So in this region, the main reservoir became the red desert fox.
Pathos vulparabica, yeah.
So if this threat establishes itself in the wild fox population, that's a huge public health challenge. You can vaccinate dogs, but, you can't exactly go out and vaccinate every fox in the desert.
Precisely. The challenge becomes endemic control. But the data shows how incredibly successful their containment has been. Between 1990 and 2017, there were only 8 human cases.
And one of those was imported.
Right. And most importantly, no local human cases have been reported since 2003. That's decades of success.
Decades of successful prevention protocols doing their job against a threat that's just constantly circulating out there in the wild.
It is, which tells you that the weak link in the chain is always that moment of exposure and the action taken immediately after.
So let's just briefly touch on transmission. It's mostly through a bite.
Overwhelmingly. But it can also be saliva getting into broken skin, scratches, or contact with your eyes or mouth.
Mucosal membranes.
But the good news, if there is any, is that human-to-human transmission is extraordinarily rare. Almost unheard of outside of things like organ transplants. It's not something you'd get from casual contact with a patient.
The fact that they've held that line at 0 cases for so long is why these clinical protocols are so strict. So let's get into the human timeline, because this is one of the most misleading parts of this virus.
This is what we call the incubation paradox.
Right.
The time between the bite and the symptoms it's highly variable. Could be a few days or it could be years.
Years.
Yes, years. Though typically it's about 3 to 8 weeks. But that variability is exactly why you cannot wait for symptoms. If you wait, it's too late.
That is terrifying.
Yep.
Okay, but let's look at the animal side of it. A key clinical decision is whether to observe the animal.
Right, and that hinges on knowing when the animal becomes infectious. The virus doesn't wait for the animal to look sick. It can be shed in the saliva for days before you see any obvious signs.
And for dogs, specifically, the sources say that period is about 10 days.
Exactly. And that 10-day window is critical for clinical management. If a vaccinated pet dog bites someone, and you can observe that dog, and it stays healthy for 10 days, the risk plummets.
But if you can't observe the animal, if it's a wild fox that runs off, that changes everything.
Everything. You immediately shift to a high-risk protocol. And for you, the listener, you need to have these red flags in your head.
Okay, let's run through them. It starts with the source. Any exposure to a known wild animal reservoir, a fox, a wolf, a jackal, that's an immediate red flag.
But you consider the nature of the attack. Was it an unprovoked bite? Was the animal acting abnormally aggressive for no reason?
The location of the bite matters too,
A
right?
huge factor. A bite to the head or neck is extremely high risk because it dramatically shortens the path the virus has to travel to your brain.
And then there are factors about the person and the animal. A bite to an infant under 1 year old, or, and this is the big one, if the animal is unknown, unvaccinated, or just unavailable for that 10-day observation.
If any of those red flags are present, the exposure is automatically treated as rabies prone.
Okay, so the official definition of a suspected case is a bite, then acute encephalomyelitis that progresses to coma or death within about 10 days of symptoms. But the whole goal is to never let it get there.
Never.
Which brings us to the life-saving steps, starting with what you can do yourself immediately.
And the sources are so emphatic about this, immediate wound care is the most critical step. Full stop.
Before you even get to a clinic.
Yes, this is non-negotiable. You have to wash the wound with soap and running water for a minimum of 15 minutes.
15 minutes is a long time. It feels like forever when you're doing it.
It is, but it's the mechanical action of flushing the viral particles away from the nerve endings. The soap is vital. Its detergent action helps break down the virus's protective envelope.
And after washing.
If you have it, a virucidal agent, alcohol, something like 40 to 70%, or povidone iodine.
Okay, now for a key clinical instruction that feels counterintuitive, do not suture the wound immediately.
Right. The rule is to avoid suturing for 24 to 48 hours. If you stitch up a wound from a rabid animal, you risk sealing the virus deep inside the tissue, giving it a perfect, protected place to replicate.
And if you absolutely have to suture it,
Then the protocol is clear. Human rabies immunoglobulin, or HRG, must be infiltrated all around the wound before you close it.
that brings us to the formal treatment categories, the PEP categories. Let's break those down.
Okay, so category UN is basically non-exposure. Touching an animal, feeding it, getting licked on intact skin. This requires no action.
Category 2.
That's minor exposure. So minor scratches, maybe some nibbling, but no bleeding. This requires wound care plus the PEP vaccine series.
And category 3 is the highest risk. This is what triggers the full protocol.
Yes. Transdermal bites. Skin is broken. There's bleeding or any saliva on your mucous membranes or any contact with a bat. This requires wound care, the PEP vaccine, and the HRI.
And if we circle back to those red flags we talked about, the unprovoked bite, the wild animal, does that automatically bump it up?
It absolutely does. If any of those red flags are present, even if the bite looks minor, you treat it as category 3, no exceptions. The standard of care is aggressive overtreatment because the alternative is just too severe.
Let's dive into that protocol. The vaccine regimen in the sources uses the Purified Virocell Rabies Vaccine, PVRV.
And it follows a very efficient schedule called the Modified Essen 211.
211. Okay, what does that mean?
It's all about front-loading the immune response. Day 0, the day of the bite, you get 2 doses, 1 in each deltoid. That's the 2.
So it's a double dose to start.
Exactly. It's a big boost to the immune system, trying to get that antibody response started as fast as possible. Then you follow up with single doses on day 3, day 7, day 14, and a final one on day 28.
The dosage is always 1 ml intramuscular, and the sources are very clear in bold letters. Never gluteal, why not?
Because the buttock region often has a lot of subcutaneous fat. If the vaccine goes into fat instead of deep muscle, the absorption is poor, and you might not get an adequate immune response. You need it in the deltoid for adults or the thigh for infants to ensure it works.
And another important point here, just in terms of public health commitment, the sources say PEP is provided free in all government institutions.
Yes, even for expatriates. It shows how seriously they take containment.
Okay, let's talk about the human rabies immunoglobulin, the HRIG. That's only for category 3.
Strictly category 3. The dose is very specific, 20 IU per kilogram of body weight. And its administration is strategic.
How so?
Half of that calculated dose is infiltrated directly into and around the wound itself. That gives you immediate passive immunity right at the entry point.
And the other half?
That's given as a standard IM injection at a site distant from the vaccine, usually the opposite arm or leg.
And there's a critical timing rule here. You do not give HRIG if the patient is already more than 7 days past their first vaccine dose. Why is that?
Well, after 7 days, the patient's own immune system should be starting to produce its own active antibodies from the vaccine. Giving passive antibodies from HRI at that point can actually interfere with that process and, potentially make the long-term protection less effective.
Okay, so we've covered when PP is absolutely necessary. What about the exceptions? When is it not needed?
The sources are pretty clear. Rodent bites, so rats, mice, squirrels, rabbits, they rarely carry rabies and generally don't require PP.
Category exposure, as we said, is out.
Right, and provoked bites from a vaccinated pet, where that animal is available for the 10-day observation and stays healthy.
What about contact with a human rabies patient, like family or hospital staff?
Also not considered an exposure that requires PP. Again, human-to-human transmission is just so incredibly rare.
Now, once prevention has failed and a patient actually becomes symptomatic, the whole conversation just changes.
It's heartbreaking. The prognosis is, well, it's the terrible truth of this disease. Symptomatic rabies is almost always fatal. There is no cure. Management becomes entirely about supportive and palliative care.
Which means isolating the patient in a quiet room and intense infection control, especially around saliva.
Yes, and it triggers an immediate public health response. Notification has to happen within 24 hours to public health and the Ministry of Agriculture. That's when the animal investigation kicks into high gear.
Let's quickly review what happens for people who've been vaccinated before if you've had PP in the past and get exposed again.
It all depends on timing. If it's been less than 6 months since your last PP, you're considered protected. No new vaccine needed.
Rather than 6 months.
Then you need boosters. For a minor Category 2 exposure, you get boosters on day 0 and day 3. For a full rabies-prone exposure, Category 3, it's boosters on day 0, day 3, and day 7.
That seems like a lot to remember.
It is. Which is why there's a simple backstop rule. If it's been more than 3 years since your last full PEP course, you're treated as if you've never been vaccinated. You get the full course all over again. The risk tolerance is 0.
So what's the big takeaway here for you, our listener?
I think it's that PEP is safe, and it is necessary. It's safe in pregnancy, it's safe for infants, it's safe if you're immunocompromised. The fact that they've maintained 0 human cases since 2003, despite this active threat from the red desert fox, just proves that strict adherence to these protocols works.
Okay, so let's boil it down to the 2 most important action items from this entire deep dive. If you remember nothing else, remember this. 1. Treat every bite from an unknown or wild animal as a potential life or death emergency.
And 2, that immediate thorough wound washing with soap and running water for at least 15 minutes. It is the single most critical life-saving thing you can do yourself.
Excellent.
And if we just zoom out to the bigger picture for a second, think about that incubation paradox. These protocols manage immediate risk. But imagine you're a public health official and a case presents itself 2, maybe 3 years after the initial bite.
How do you even begin to trace that?
Exactly. How do you trace that exposure back to the source? Trying to pinpoint which animal interaction from years ago was the one that broke through. It's a terrifying retrospective.
A challenge built entirely on the assumption that prevention somehow failed years earlier. That is something to mull over. That's all for this deep dive. We'll catch you next time.
Hit the like button and subscribe to the channel for more videos like this intro.